In this video, we are going to explain about acid-base disturbance that we can see in ABG analysis. Actually, what to look and conclude for our patient? How can I know the patient is having acidosis or alkalosis? That we are going to learn from this video. The main learning objectives are comparison of ABG and VBG analysis, difference between ABG and VBG. Then I am going to show you a VBG result. Then regarding the oximetry values. The main thing which we are going to learn from this video is the step-by-step learning of ABG analysis. Regarding the pH, type of acidosis and alkalosis, ROM, characteristics of acid-base disturbance, compensation, examples of respiratory acidosis disease, respiratory alkalosis disease, metabolic acidosis disease, metabolic alkalosis disease. Then the main thing, we are going to see some selected, mixed and complex acid-base disturbance. Here I am going to explain the main difference between ABG and the VBG blood result. The pH will be almost similar. The arterial will be 7.38 to 7.42 and the venous will be 7.35 to 7.38. But the oxygen and the carbon dioxide values will make the result different. When it comes to the arterial blood, the oxygen level will be 90 to 100 mm of Hg and the carbon dioxide level will be 38 to 42 mm of Hg. When it comes to the venous blood, the oxygen level will be less and the carbon dioxide level will be little bit higher. So the oxygen will be 40 mm of Hg and the carbon dioxide will be 44 to 48 mm of Hg. And regarding the bicarbonate, in arterial blood we can see 24 milli equivalent and in venous blood we can see 21 to 22 milli equivalent. The main difference we can see in arterial and venous sampling is the difference between oxygen and the carbon dioxide level. In an arterial blood sampling, the oxygen level will be 90 to 100%. And in a venous blood sampling, the oxygen level will be 40 mm of Hg. With this difference, we can differentiate the venous blood sample and the arterial blood sample. Here I am showing you a VBG sample result. By looking at the carbon dioxide and the oxygen level, we know that this is a VBG result. Here we can see the reference value, that's 41 to 51 for the carbon dioxide. And the oxygen level is 30 to 40. And the pH is 7.31 to 7.41. Then from the VBG sample, we are going to look the oximetry values. In the next slide, I am going to explain what is oximetry value and what we are looking at oximetry values. The other information that we get from a VBG sampling is electrolyte value and the metabolites value. Even the same things we can see in the ABG result also. In oximetry value, actually we are looking the total hemoglobin. We are going to rule out the anemia of a patient. The concentration of total hemoglobin in blood, that includes the oxygenated hemoglobin and deoxygenated hemoglobin. As well as there are some other dysfunctional hemoglobins that are incapable of binding the oxygen. Once again I am saying that the total concentration of hemoglobin CTHB will be equal to oxygenated hemoglobin CO2 HB plus deoxygenated hemoglobin CHHB plus carboxy hemoglobin plus meth hemoglobin plus sulf hemoglobin. Next we are seeing the oxygen saturation. The oxygen saturation is the ratio of oxyhemoglobin concentration to concentration of a functional hemoglobin, that is oxyhemoglobin O2HB and deoxyhemoglobin HHB. These are capable of carrying the oxygen. The oxygen saturation reflects utilization of the currently available oxygen transport capacity. In arterial blood, we should have 98 to 99% of oxygen, and that is transported in erythrocyte bound to hemoglobin. I am going to explain about bilirubin. Bilirubin is one of the metabolites we can see in the ABG result. Bilirubin is the yellow breakdown product of hemoglobin. It is transported in blood from its site of production, that means from the RBC, to the liver, where it is biotransformed before excretion in bile. We can see yellowish discoloration of the patient, that means jaundice. It is due to abnormal accumulation of bilirubin in the tissue, as it always associated with elevated blood concentration of bilirubin, and we can rule out hyperbilirubinemia in ABG or VBG result. The next thing we can rule out lactate. Lactate has been widely considered as a marker of tissue hypoxia. High levels of lactate are associated with increased risk of death independent of organ failure and shock. Cause of hyperlactemia. Why this lactate is increasing? When there is a reduced tissue oxygen delivery, for example, anaerobic muscular activities like heavy exertions, when patient get seizures, severe asthma, global hypoperfusions like shock, cardiac arrest, heart failure, regional ischemias like mesenteric limb burns, trauma, compartment syndrome, soft tissue necrosis. There will be reduced tissue oxygen delivery in severe hypoxia, severe anemia, carbon monoxide poisoning. The first thing we have to look at in the VBG or in a ABG result is the patient blood is alkaline or acidic. For that we have to look the pH. If the pH is less than 7.35, it is acidic. If the pH is more than 7.45, then it is alkaline. So the blood should always contain a neutral value of 7.35 to 7.45. That means not acidic, not alkaline. The second step is that we have to find out what kind of a disturbance patient has. Is it the respiratory or the metabolic? When we see the pH less than 7.35, it is acidosis. Then we have to look for whether it is a respiratory acidosis or a metabolic acidosis. The second thing, we have to look for the pH. If the pH is more than 7.45, then we have to look what kind of a alkalosis it is. Is it the respiratory or the metabolic alkalosis? In step 3, we are going to find out the relationship between the pH and the carbon dioxide. I am going to give you a short form, a ROM. ROM stands for, R stands for respiratory opposite. That means in the respiratory disorders, the pH and the partial carbon dioxide change in opposite direction. ME, metabolite, is equal. That means in metabolic disorders, the pH and the carbon dioxide change in the same direction. Here we can see the respiratory are in opposite. The pH and the carbon dioxide in respiratory is opposite. We can see the metabolic. The pH and the carbon dioxide are in equal or same direction. We are going to look the characteristics of acid-base disturbance. In the first column, we are going to see the disorders of metabolic and the respiratory. Then we are going to see how the pH changes and the primary problem in each disorder, and how the compensation occur in acidosis and the alkalosis. The body compensates in two ways, by respiratory system or by the kidney. Let's see metabolic acidosis. The pH will be decreasing and the primary problem will be seen in the bicarbonate level, and that too decreased, and the compensation by the respiratory system by decreasing the carbon dioxide level. In metabolic alkalosis, pH increases, bicarbonate level increases, and the compensation by the respiratory system increasing the carbon dioxide level. In respiratory acidosis, we can see the pH decreasing, increased carbon dioxide level, and the increased bicarbonate level. In respiratory alkalosis, the pH increases, decrease in carbon dioxide level, and decrease in bicarbonate level. In ABG result, we have to look, is there appropriate compensation for the primary disturbance? Usually compensation does not return the pH normal to 7.35 to 7.45. If the observed compensation is not the expected compensation, it is likely that more than one acid-base disorder is present. Respiratory acidosis usually seen in airway obstructions like upper or lower airway, in COPD, asthma, other obstructive lung diseases, even in central nervous system depression, sleep disordered breathing, neuromuscular impairment, when there is a ventilator restriction, increased CO2 production in case of shivering, rigors, seizures, malignant hyperthermia, hypermetabolism, increased intake of carbohydrates, incorrect mechanical ventilation setting. In these conditions, we can see respiratory acidosis. Respiratory alkalosis, we can see in some of the disease conditions. Let's go through one by one. In central nervous system stimulations like fever, pain, fear, anxiety, CVA, cerebral edema, brain trauma, brain tumor, central nervous system infections, the respiratory alkalosis can be seen. Other conditions like hypoxia or hypoxemia, such as lung disease, profound anemia, low FiO2 situations. Even in chest stimulation receptors, like disease conditions like pulmonary edema, pleural effusion, pneumonia, pneumothorax, pulmonary embolus. Other causes are like drugs and hormones, for example salicylicates, catecholamines, midoxyprogesterone, progestin. In pregnancy, liver disease, sepsis, hyperthyroidism. If there is any incorrect mechanical ventilation settings, we can see the respiratory alkalosis. Metabolic acidosis, that can be seen in uremia, diabetic ketoacidosis, alcoholic ketoacidosis, starvation ketoacidosis, lactic acidosis, for example tissue ischemia and altered cellular metabolism. Even in gastrointestinal loss of bicarbonates such as like diarrhea, ileostomy, proximal colostomy, urethral diversion. If there is any renal loss of bicarbonate, we can see the metabolic acidosis like proximal RTA, carbonic anhydrase inhibitors. Then there is any renal tubular disease like a chronic renal disease, distal renal tubular acidosis, aldosterone inhibitors or absence, sodium chloride infusion and total nutrition. In such case we can see the metabolic acidosis. We can look some metabolic alkalosis conditions. When there is hypovolemia with chlorine depletion, for example gastrointestinal loss of hydrogen ions, when there is vomiting, gastric suction, villus adenomas, diarrhea with chloride rich fluid. Even we can see renal loss of hydrogen ions from the loop and thiazide diuretic use. Post hypercapnia, especially after institution of mechanical ventilation. And another thing is hypervolemia with chlorine expansion. Chlorine expansion in renal loss of hydrogen ions can be seen. Edematous status like heart failure, cirrhosis, nephrotic syndrome, hyperaldosteronism, hypercortisolism, excess ACTH, exogenous steroid, hyperenemia, severe hypokalemia, renal artery stenosis, bicarbonate administration. In such case, we can see the metabolic alkalosis. Let's see some selected, mixed and complex acid-base disturbance. Here, I am going to say the disorders. Then we are going to see what type of things we can see and what situation that will be seen. First of all, the respiratory acidosis with the metabolic acidosis. In that, we can see decreased pH, decreased bicarbonate and increased partial carbon dioxide. Especially seen in cardiac arrest, intoxication, multi-organ failure patients. The second one is respiratory alkalosis with metabolic alkalosis. In that case, increased pH, increased bicarbonate and decreased partial carbon dioxide. We can see in cirrhosis with diuretics, pregnancy with vomiting, overventilation of COPD patients. The third one is respiratory acidosis with metabolic alkalosis. In that case, the pH in normal range. Then we can see increased partial carbon dioxide and bicarbonate level. Especially this situation seen in COPD with the diuretics, vomiting, NG tube suctioning, severe hypokalemia patients. The fourth one is respiratory alkalosis with metabolic acidosis. In that case, the pH will be in the normal range. The other two, carbon dioxide and the bicarbonate will be decreased. Especially seen in sepsis, salicylic toxicity, renal failure with congestive heart failure or pneumonia, and in advanced life disease. The last one, it is the metabolic acidosis with the metabolic acidosis. In that one, the pH is in the normal range and bicarbonate in the normal range. Especially seen in uremia or ketoacidosis with vomiting, NG tube suctioning and diuretics. I hope so you understood how to look and what to look in a ABG report. Thanks for watching.